Hello and welcome again to another edition of the Osteopathic Lyceum podcast. I'm going to try to cover a few things. The first thing I want to discuss, sorry, I'm just going to click something real quick here. Nope, that's not the one I wanted to click. Sorry. I've got papers ready to point to, so I'm just trying to make sure that I don't lose them on my phone. And I could have easily done that before I started filming, but here we are. So the first thing I want to do is talk about the concept of a construct. So I've done this before in multiple ways. One of the reasons I want to do this is because in order to try to understand on a group level what is going on with something is that you have to have something. So something could be a construct, not could be, is a construct, okay? What could that construct be, or what types of constructs might you find? Well, you have to have a term that describes something that seems to be a stable and consistent phenomenon, and then you can apply that concept or that construct to a bunch of different people. Then you constitute that as a group. You want to have something that's similar between them, whether that similarity is they live on the same block, they were born in the same hospital, they went to the same school at a certain age, they went through the same university program, they work at the same hospital, they ride the same style of bike, whatever it is. There has to be something similar about these people to make them become a group, which means that you are focusing only on the similarity and not on the variable differences that are likely present in each one of these individuals when compared to all of the other individuals that happen to fall into the group. So in order to check something at the group level, you have to identify similarity and minimize or ignore difference. It is just a quirk of how that works. So the construct is the first thing. You need the construct. You need the thing that you want to observe. Then you need another construct in the form of a group that you have to identify and defend the similarity. So the first thing being the construct. Well, the construct, again, is supposed to be a stable, consistent phenomenon. Unfortunately, as far as we can tell, most phenomena within humans or within a population, so individuals or individuals that then constitute a population, there is variability in all those phenomena when checked at more of a granular level. The most straightforward example that I have that has shown this with constructs across population in what is likely an exceptionally trustworthy way is the theory of constructed emotion. So an emotion, there's a category of emotion. So there's a stable phenomena that you could have some definition that you would identify what the term emotion means and how it's stable between individuals and how you can identify it almost anywhere you look. Then you need to have subdomains or subphenomena in the specific named emotions. Under any specific named emotion, no matter what you try to measure, you see variability between people. So while the same term, the same construct, or the same concept is used, or the same heading is used, be it anger, joy, sadness, happiness, whatever the term is, you see variable signatures between people. So if you try to measure things such as galvanic skin response, things such as perspiration, respiration, heart rate, brain electrical activity, things like that, so functional MRIs of the brain, what you notice is that there is not a stable signature between people when they report the word. What that should identify for us is that there are challenges with constructs that you're going to attempt to apply to people. So when you look at a condition, when you look at a medical condition of any form, while the condition is named the same because you have diagnostic standards and some of those diagnostic standards acknowledge the variability. So let's just say there's 18 symptoms for a particular thing or 18 signs. Let's say 18 signs. If somebody has 15 of them, then you can consider them having that condition, which means that it is acknowledged that while the diagnostic may be accurate to the diagnostic standard, there is variability between people to get to the point where I can call it this thing. So the variability is acknowledged in the tool to identify the condition, but when you try to go and check it on the population level, you don't tend to do things like count the actual diagnostic criteria hit, how often that happened. Like, you can do that on the diagnostics, and that's how you develop your diagnostic tool so that people hit it. But then when you want to study the condition at the population level, you sort of ignore that. You don't ignore it completely because it's in the underlying data, but you don't pay attention to it because you're trying to get the population phenomena or the large phenomena. The problem is that to get to the condition or the word that describes the condition, I have to acknowledge the variability, put it into my tool, and then I can build something on top of it. So the flaw at any point that is constant with large-scale stuff is that you erase or minimize the variability between people that is acknowledged to get to the accepted level to term somebody having that condition. So maybe a better way to say it is, you slap a label on somebody and you acknowledge that when you slap that label on them, they're different than other people with that label, but they're similar enough that you say, they're the same. And then you do some kind of analysis at the population level. So we've created that sameness while acknowledging the variability, but we're trying to minimize and erase or not pay attention to that variability. Then we put it at the population level. So from ground level, there's assumptions built in. If you are not willing to acknowledge those assumptions, you will then fall down at clinical application or at the clinical level or the interpersonal level. So in order to get to population level, I have to make assumptions. Those assumptions are I have to minimize difference and magnify sameness. Then to create the population, I need to identify whatever the similar thing is. At least in healthcare, the sameness is the named condition. So, that said, hands-on manual therapies, because of the environment of observation, we're outside of the patient, most of the things that would allow us to identify a particular condition are not available to us outside of very specific circumstances where people are legally allowed to do some form of diagnostic that would be able to peek inside through what's easily termed extrasensory perception in, say, a blood test or an image of some form, so radiology. If you can't do that, then you can't even get close to honestly identifying a condition at the level of rigor that we would accept today, which is probably going to change in the future. We may actually have more rigor in the future in all likelihood. So we can't even, as osteopathic manual practitioners or RMTs or physiotherapists, and our physiotherapy might be mildly different and they can argue this, but our ability to get to accurate diagnostic of condition is really incumbent upon our ability to get to the rigor that would allow us to name that condition, and we just don't have access to that. We don't have the time. We don't have the equipment. And sometimes we don't have the legal right. I don't have the legal rights to, quote unquote, diagnose a condition, which I'm completely fine with. So just keeping in mind that in order to get to population level, you need to minimize difference and magnify sameness. It's a constant challenge. If you like things at the population level, then you are minimizing difference and magnifying sameness. Yes, you're doing it in a defensible way because you're looking for a pattern that you feel like you can trust. But I'm going to tell you, when you read the things at those levels, they do not inform you how to deal with the person who's in front of you. They can inform you of a great place to start, but you must adjust. It's just a thing. It's just a constant phenomenon. So Also, I do read systematic reviews, I read meta-analyses, and my trust doesn't often go up. It's very unfortunate. My trust doesn't go up. One of the things that's the constant finding of any form of aggregated review, whether it's a scoping review, systematic review, or meta-analysis in other format, is they consistently talk about how there's issues with the quality of the research. So, again, my contention as a result of that is teach the basic scientific skills better. Don't teach the ability to read the science. Don't teach the ability to, judge it or... there's another term that's escaping me at the moment, but, put a confidence level on it. Teach the actual basic science skills. the terms ontology, epistemology, axiology, principle of parsimony should be simple things for you. They should be more or less automatic, and you should ideally be capable of defining them and acknowledging that other people would have a difference of how they would define them. And then be able to identify when one form of epistemology would be more appropriate depending on what it is that you're trying to study. So anyways, 10 damn minutes talking about that because clearly I can just go. What I'm going to do, and what I hope is a quick manner from the Journal of Osteopathic Medicine, I'm going to display a paper that kind of grinds my gears, not because the authors did anything that's not acceptable, but because they're not necessarily helping improve anything with what they did. They're just showing, that Mikey liked it. So I don't know, a lot of you will not have the cultural reference for that, but it was it was food product. I just don't remember the exact food product. I'm pretty positive it was cereal. There was an older brother and his friends, I think, and a younger brother, and they basically tried to see if the cereal was good by giving it to the younger brother, and then it was like, Mikey likes it, right? So as a flippant colloquial category, there's a lot of papers that it's like, hey, Mikey likes it. That's awesome. So the paper I'm going to look at first, I will give you the date. So it's August 30th, 2022 is when it was published. The title is Cadaveric Dissection Essential in Medical Education, a qualitative survey comparing pre- and post-COVID-19 anatomy courses. So one of the things I want to note really quickly, because when you get into the full text of this, they note that there's a problem-based learning group and SGL. What did they say was SGL? It's two different instructional approaches. SGL. Oh, darn it. Maybe it's just straight in the abstract. Sorry, give me just a moment. Do they have it in the abstract? They don't. Anyways, it's problem-based learning is, there we go, synergistic guided learning. Okay, it's a new acronym that I think means damn well nothing. So I'm just going to read this really quickly. This is from the full text. I'll get back to the abstract in a minute. I just want you to know that sometimes the abstract does not necessarily give you some of the highlights that you need to have to be able to really interpret it, and full text is very important. The Journal of Osteopathic Medicine seems to be doing an absolutely excellent job of making sure that full text articles are available for free to people who would be interested in reading them. So kudos to them for that. Where'd we go? Okay, so this is just the definition from the paper. PBL curriculum utilizes a self-directed group learning strategy, whereas the SGL curriculum follows traditional lecture-based learning. I would not completely buy that. Problem-based learning traditionally has small groups, so you're assigned to a group, you're going to have a TA. Each group within the tutorial group is going to have different things assigned to them. You go out, you try to solve the problem, gather research. So you're ideally working on information retrieval skills and self-guided approaches. And then you come back, you present, and the presentation allows you to inform your peers about the thing that you did, and they inform you about what they did. It's, small group, small size. The only benefit of PBL is that Mikey likes it. Students say they like it. It doesn't do anything to performance when compared to other approaches. Synergistic guided learning, it's a new acronym that I have not seen as yet. It doesn't mean I haven't seen something similar, but synergistic guided learning, when they say it's traditional lecture-based learning, I don't know if I buy that, because there's a fancy term and they would have, in all likelihood, some other specific things. This is at a specific school. It's the Rowan School of Osteopathic Medicine, I believe. They're likely trying to compare delivery approaches so that they can choose what they stream into and just use that one because they've proved that it's better. Unfortunately, for student performance, especially at the medical school level, you're not going to see much difference in approaches, but you will see differences in whether or not the students say they like it. When asked about whether or not students like the single thing that they did, they often say they liked it. Not exclusively, and that's probably contained in here. But if you don't know any different approach, then yeah, you like it. Or if the approach is different to what you're used to, the new one is cool. So I guess I like it. So it's a bit of a challenge. So I'll go back to the abstract just so that I can tell you why this grinds my gears. So the context: with the surge of the novel coronavirus, SARS-CoV-2, COVID-19, the modality of teaching anatomy has shifted from in-person cadaveric dissection to virtual lessons for incoming first-year medical students. As a result, we aim to assess the impact of this curriculum change has had on student perspectives. So they do tell you it's perspectives. I acknowledge that whether or not students like something matters because it impacts engagement. If students will not engage, then they can benefit in no way from the content of a course. But I don't need them to like it. I just need them to not turn away from it. If I want to know if it's valuable for me as an institution, what I really would like to see is both the engagement level, so the stated enjoyment. I would also want to see things like attendance, things like other measures of engagement within a particular classroom, not just ask them if they like it. I would like to see if they engage at varying levels or in varying ways. And then I would also want to see a performance metric. So I want to see, do they do better on my assessment tools? So if my assessment tools, if the performance improves, I like it as an institution. But otherwise, I'm not going to spend the time or money. I'm just going to keep doing what I'm doing instead of changing, because the change at an institutional level takes time, money, and effort, which you don't always have, and you're going to almost always have resistance to change. So, if people are teaching whatever the SGL way is, and then you ask them to do PBL, the instructors might get pissed, and they might not do it. So whatever benefit might be present in the difference, I can't get to because of the behavior change. So it's got to be a lot better for me as an institution to be willing to change to another method of delivery. Results. No, let's look at the methods. Oh, the objectives. Yeah, crap. Okay, let me read quick. The study aims to understand the relative effect of a virtual anatomy course implemented during the pandemic, 2019 to 2020, on the confidence, skills, and perspectives of first-year medical students compared to medical students who had traditional in-person anatomy at Rowan University School of Osteopathic Medicine in Stratford, New Jersey. Methods. The authors developed a 14-question survey to target gross anatomy students of the classes of 2023 and 2024 at Rowan SOM. The class of 2024 had a virtual anatomy lab compared to the class of 2023, who had an in-person anatomy lab in their first year of medical school. The responses were analyzed to understand the difference between a hands-on cadaver lab and a virtual anatomy lab utilizing SPSS. That is a statistical, it's a stats program. It's stats software. The reason that I'm not going to care much about whether or not they like the virtual program is because I happen to be well aware from research that comes out of McMaster from primarily as lead investigators, Dr. Bruce Weinman and Dr. Danielle Brewer-Deluce. I believe it's Deluce. It could be Delucci. I need to ask her in person how to pronounce her name. She's a wonderful researcher. She's a strong presenter, so I need to ask her how to say her name properly. But they looked at the performance outcomes of varying delivery methods, and a standard plastic model outperforms all other methods, whether it's VR or simulated 3D. So the actual physical model outperforms all other forms of learning on an assessment metric, which is accurate identification of landmarks of structure. So immediately, whether they like it or not, when there's no related performance metric, I'm not going to be that concerned, right? So the results. The survey was administered to approximately 400 people, from which we received 149 responses, 37.3%. That is really normal. Response rates on surveys are low. People who will respond to surveys are similar to one another. Therefore, the voices that are not included are never heard. Therefore, any conclusion from a survey, especially when I see a low response rate, I cannot trust as accurate to the population that didn't respond. I can only trust it as accurate to the population that did respond. And I may not care about their responses. I might actually want to know about the people who didn't respond. So, yeah, you got a survey, a low, 37.3 is not a bad response rate. That's a pretty decent response rate. We're really close to 40%. But, this is not indicative of the student population at large. So I don't even know if the student population at large likes it. I know that, I got some result at 37.3%. Among all responses, 36.2% number was 54, belonged to the class of 2023 who encountered hands-on cadaver experience, whereas 63.8% of the respondents, number was 95, belonged to the class of 2024 who gained virtual anatomy lab experience. An independent t-test statistical analysis was utilized under the confidence domain when students were asked about the understanding of trauma after the respective anatomy labs. 64% of the class of 2023, 50 showed significantly higher confidence compared to 15.4% for the class of 2024, was 78. So the ones who had the in-person anatomy lab, the cadaver lab versus virtual, had more confidence in their understanding of trauma. Under the skills domain, the class of 2023 felt more comfortable with ultrasound, that's 64%, identifying all of the pertinent anatomical structures in their respective locations on imaging, 72%, and identifying the pathology. Only 36.9% of the class of 2024 respondents shared similar comfort with ultrasound. The conclusion. So while this is lining up more or less with what I would expect based on what I understand about performance metrics with varying anatomical delivery, I don't know that I can buy the rationale, because getting this in 2019, starting your education in 2019 at a medical school level versus starting in 2020 were very different cultural experiences, and that hasn't necessarily been controlled for. Some people can be just highly convinced that because their experience was different than what happened before them, that it was somehow not as good. So I don't know if I'm going to put a lot of faith into this. If I saw performance, so let's just say somebody thinks they're not very good at something and then I test their performance and they're good at it, then it's just a difference between how they feel about themselves versus how they perform, right? So I'm going to trust how they perform versus how they feel. I'm going to try to work on how they feel because that's where the lack is. But if somebody feels really good about their ability and then I test them and they perform really poorly, well, I still have to work on your feelings because your feelings don't match reality. So the conclusions here. Based on current results, it can be established that medical students who had in-person cadaveric dissection had a favorable attitude towards their anatomy course compared to students who had virtual anatomy during the COVID-19 pandemic. So again, I can't differentiate whether or not it was just the fact that these people went into a program when there was major cultural events happening and major policy events happening. So behavior was changed by policy around the world in pretty major ways, and that can have an impact on a person as opposed to an impact on performance. What I will note, though, is anatomy performance, at least with respect to identifying structure, is definitely better when 3D plastic models are used. And cadavers are obviously essentially a 3D model versus any other delivery format. The other delivery formats do not perform as well. They're more expensive, so why the hell would I do them? If it's more expensive and it doesn't perform as well as what I'm already doing, I'm not changing for a goddamn thing, right? So at least here, the conclusion is they like the cadaver better. So yay, Mikey likes it. Now, in this case, because it lines up with knowable improvements in performance from other research, I'm okay with supporting this, but not for the reasons of how this was done. So if you don't give me a performance metric while telling me whether or not while telling me how much the students like something, you don't have my ear. I'm not going to be even willing to consider changing anything. If they like it and it improves their performance, I'll change. If they like it and it does nothing to their performance, I don't care, right? As somebody who would be running an institution, I wouldn't listen to you at all. If you can't show me the performance and liking it, we've got no change. We've got no impetus for change because I have to fight through the implementation and the behavior change through multiple layers of faculty that have been doing something a particular way for a long time. And because they've done it for a long time and they've had whatever success they've had, they're just going to flip you the bird, right? So no, if you can't show me that it improves performance, we've got nothing to talk about, right? So if you're thinking about regulatory level or curriculum level, I don't care if you like it if it doesn't improve performance. I need to see it improve performance before I'll implement it. So whatever idea you have, if you can't show me that it improves performance metrics or patient outcomes, we're not talking. It's done, right? So there we go. Anyways, now I'm going to show you the one that I liked. Okay, so the one that I like and the reasons that I like it, we'll go through here. So this was from January 27th, 2023, again, Journal of Osteopathic Medicine. Does the osteopathic pedal pump reduce lower limb volume in healthy subjects? Okay, so they're very clear, healthy subjects, not people with lymphatic issues. This is a pilot study. This is kind of trying to see if there's some signal that would allow me to have confidence that I should apply this in people with pathology. It is ground level stuff. It shows you exactly why it's doing what it's doing, why it's doing it to the population that it's doing, and what it's hoping to find. And then if it finds the signal, let's go, right? I'm going to read the abstract. I might have to, will I have to? I don't think I'll have to get into the full text because the abstract does a pretty good idea. I might get into a little bit of the full text. Anyways, the abstract. Context. Lymphatic treatments are gentle and passive techniques believed to enhance movement of lymph back into the central circulatory system. Animal studies provide supportive evidence, yet there are a few studies in humans. That does a really good job of noting the intro and the literature review because they talk about specific animal studies and then they talk about the lack of human studies. Also, this is well written as an abstract because there's this specific sub portion of that sentence. Passive techniques believed to enhance movement of lymph back in the central circulatory system. That's a fantastic thing because they're not saying we know. We're saying it is believed, right? The objectives. The aim of the study is to investigate whether the osteopathic pedal pump protocol reduces volume in the lower limbs of healthy subjects. So they tell you exactly what they're aiming for. So they're going to use healthy subjects. They're going to do pre and post measurement of volume. It's generally a fluid volume in the leg or the lower limb rather. So methods. A total of 30 first and second year medical students were recruited. Subjects were excluded from participating if they had acute asthma, chronic obstructive pulmonary disease, congestive heart failure, active infections, fractures of the lower extremities, or metastatic cancer. Within subject study design with pre- and post-treatment measurement of lower limb volume was utilized. Pre-treatment lower limb volume measurements were obtained utilizing a volumetric water gauge prior to myofascial thoracic inlet release and a 5-minute pedal pump lymphatic protocol or pedal lymphatic pump protocol treatment. Post-treatment lower limb measurements were taken immediately following the protocol treatment. A telephone interview was conducted 2 to 3 days later after the treatment to assess the participants' experience of the treatment and whether the treatment elicited a subjective change from baseline. A paired t-test was utilized to determine the statistical significance of volume displacement post-treatment. So they did something really interesting here that actually matters and shows the stuff that I would prefer to see as somebody who would be considering behavior change. So whether it's at the institutional level or at the practitioner level, what they did is they included both objective measures of whether or not this changed the thing I wanted to change and asked people whether they liked it. So if I can see that they like it and it does something to the target measurement, I have more confidence. I'll fight for this. This is worth changing, right? But if it improves the target measurement and the people don't like it, then I might have to be more picky about who I apply it to and why I apply it to them. I might need to gather more contextual factors to say, hey, you might not like this, but it's going to be really good for you, right? Because we have to consider autonomy. If the patient is not going to likely appreciate the treatment being applied to them, then I need to allow them the opportunity to say yes or no and provide them with the information. So we're considering autonomy very much here. So if I get a signal that generally people like it, they had a positive experience, and it improves the target measurement, let's go. We're on a good track here. So that's actually a pretty good base level design. So to the the experimental design team, good on you. Results: the mean change of pre-treatment to post-treatment lower limb volume was negative 45.63 milliliters with a standard deviation of 37.65 milliliters. Okay, so that's a pretty big standard deviation. That's almost the size of the total average change, or mean, median, mode. Yeah, mean, the average, what most people would consider average. Change between pre-treatment and post-treatment volume measurements was statistically significant. The minimum displacement was plus 19 milliliters, so somebody actually went up. Their lower limb volume went up. The maximum displacement was negative 167 milliliters, so that's what was removed. 167 milliliters was more or less removed, or moved, not removed, moved. The majority of participants perceived the treatment as effective and enjoyable, were likely to recommend it to others, and were willing to have it performed on them at routine office visit if there was a need. So we generally have a positive outcome on measured volume change, and with at least one person going the way that you wouldn't want them to go, more fluid ended up in the lower limb. And generally, we have a positive signal. They liked it. They'd do it again, or they'd have it done again. Conclusions: the osteopathic pedal pump technique, when utilized on those without leg lymphedema, reduces lower limb volume as measured by the volumetric water gauge. Further studies are warranted, especially in persons with excess lower extremity edema, lymphedema, or venous stasis. So we have a study that is very narrow in that it is looking at an exceptionally specific method. We get a positive signal out of the target measurement, the change, and a positive signal as far as acceptability, enjoyment, positive feelings towards the application of it. Because really, you're just standing at the foot of the table, more or less. You've got control of the person's feet, and you're trying to make their whole body wiggle by essentially creating ankle plantar flexion and dorsiflexion, right? As an analog, you could see how walking would be fantastic for this, because you get full body wiggle, rebounders, so the small trampolines that people can kind of bounce around on and are promoted for lymphatic drainage. Maybe you could see where you could recommend that to somebody. One of the reasons that you might argue that you prefer the pedal pump when somebody's laying on their back is because they're not necessarily having pressure from vertical pressure on the lower limb that would make it harder for that low volume lymphatic fluid to move out of the lower limb. So you put somebody on their back, and now it's no longer a vertical column of fluid. You've changed the dynamic of it to some degree, and then you're shaking them, right? You could say, maybe get somebody to lay down and have some vibratory mechanism, whether it's like a good old magic fingers bed or something that oscillates them, something that shakes. You could maybe investigate that further, because you want to try to find whether or not the mechanism is consistent, whether it's the pedal pump itself or whether it's just the wiggle, and whether positionality makes a difference. But if it is an acceptable treatment and it has the impact on the target outcome or the target measurement, we're in a good spot. Whereas with the educational study, the feelings of efficacy or the feelings of confidence towards understanding particular things, whether I got a cadaver as my first anatomy experience or whether I got a virtual lab as my anatomy experience, there's no performance metric there. So I know how you feel, but I don't know what it did. The other thing that I do want to highlight is that with the measurement of the pedal pump or the pedal pump, there was notation that there was at least some observation that the amount of fluid measured in the lower limb by the measurement they used, so you have to trust the measurement they used, it has to be accurate. They would have, and when I looked at the full text, they did describe it well. They described how they did it, so you could reproduce it. And it seems like a reasonable measurement. It's essentially a displacement measurement. So you put their leg in water and you're looking at displacement under the assumption that the change in displacement means that there's something more in that limb. That limb got heavier. So you're assuming then that it is that it's fluid. Now, that would have been tested across a bunch of different circumstances. So your confidence that that's actually what it is can be decent. You're not directly observing the fluid change. You are assuming it based on the methodology. So it's a proxy measurement. But at least with that proxy measurement, you have some reason to trust it because you did it the same way. So, but the fact that there's a wide range of change, mostly in the positive direction, but some in the negative direction, so increase in fluid, we have identified that under the same construct, with the same method, so I've got the same construct of lower limb fluid, and I'm measuring it against the same application of treatment. So they do a myofascial release for the STA, the superior thoracic aperture. So they basically, grab your neck and, or like the ring at the base of your neck and your clavicle, first rib. So what is it? T1, first rib, clavicle, manubrium, that ring, and they try to manipulate that, and then they'll shake you for 5 minutes. So that's sameness. Right. So the sameness is the measurement and the application. The difference is the variance between the people. And we actually see variance in change of lower limb fluid volume. So we have a construct, lower limb fluid volume. We have another construct of intervention application. And we have variance under the constructs. The variance is chronic. So we would need to then, if we really want to understand who to do this to, understand what the factors are that will have those people increase the volume of fluid in the lower limb versus those who will have it decrease. And also, the standard deviation is pretty big. So the larger the number with standard deviation, the more that I know there's variance. So the variance is large, not necessarily unacceptable. I do know that on average, this is going to change lower limb fluid volume in the way that I would prefer, but I also know that it'll go the wrong direction sometimes. I need to know more about that. So there's actually a good amount of research and experimentation that could come out of this so that I could have actual confidence that I could identify who would benefit from this as opposed to what it does to the population. Because as a healthcare practitioner, I don't care what it does to the population. I care what it's going to do to the person I'm interacting with right now. And I need to know the factors that would make me more confident that it would impact this person in the way that I want it to versus less confident. So, if you like systematic reviews, we need better basic science. We need to answer those questions better consistently so that when people go and do systematic reviews or meta-analysis of any form, they have higher quality evidence that they can actually pick between. And it would be useful to have methods and math that is similar enough that you could actually meaningfully compare these studies and identify the factors. So, yeah, the pedal pump or pedal pump study has both an objective target measure as well as a subjective reported measure, where the education one just has a subjective reported measure with no performance measure. I kind of want the performance measure if you're going to try to tell me that something's awesome and that I should attempt to apply change to a large group, right? So be cautious with these things. If you listened this far, thank you for listening. Hopefully you've learned something. We'll talk again soon.